Hi, this is Brian Kim. I want to share with you this case of a Bioniko BR8 cataract surgery simulation model. And this is my first experience and impression using this cataract surgery simulation model by Bioniko. And so as the folks at Bioniko have told me, this is really a maneuver simulation, not tissue stimulation surgery. In other words, it's not going to be exactly like the real patient, a human being doing cataract surgery as far as the tactile sensations. However, hopefully this will help give learning surgeons an idea of what it feels like to do the maneuvers. And so you can see this is the model. You have a syringe with water attached to the side. And what this does is it creates some pressure in the vitreous space, so you can irrigate fluid into the vitreous space to keep the eye nice and formed. And so you can see here, I made my incision, but then I realized that that syringe is going to be in my way. So I go ahead and move positions here and I make my paracentesis incision. Again, like I do in my standard cataract surgery, I'm going to make an incision first on the right side and then the left side. And of course, because this is a model eye, it's hard to really know where the limbus is. So I'm just, doing the best I can, making sure I'm flat to the iris plane, just like I do with my regular cataract surgeries, making sure I do enter into the anterior chamber. And you can see the eye looks rather shiny, and that's because there's no viscoelastic in yet. And so here's the viscoelastic. As I push it, you can see now, you can see the intraocular tissues much more clearly. That reflection off the tissue itself is gone once the viscoelastic is in. So using the cannula to hold the eye, and I'll make my main incision. And I'm just being very careful here. You can see that the tissue does not really simulate human tissue. You can see how it's kind of deforming and there's a lot of friction as you're advancing the blade. Of course, that does not happen in human tissue. There's a lot less friction. It just cuts right through. With this artificial eye, of course, there's much more friction because it's not real tissue. So these are the sharp tip LD Percars. I'm going to puncture the center here. And I first tried putting some water on the cornea. That really didn't work. And so I'm just going to go ahead and wipe that water off the surface now. And then I'm puncturing the center and I'm pulling down towards me. You can see there's the beginnings of a flap there, grabbing the right side of the tear. And now you can see, again, the capsule tissue is rather thick and stiff. And in that regard, it is not like normal capsule tissue. Normal capsule tissue is much more thin and it collapses on itself, much more like wet tissue paper. Whereas this is more, you could tell it's thicker and stiffer. You can tell it has that plastic consistency, which is not like a true capsule tissue. And you've seen in my other cases with the medical students, the flap actually tends to want to go back into the proper orientation. It likes to flatten out again. So when you fold over that flap, it doesn't tend to stay there. Again, doesn't really simulate human tissue, but the idea is you kind of get an idea of how to perform the rhexis. You go around circumferentially, you have to redirect your forces, you have to learn how to work within the incision without oar-locking yourself, pivoting within the incision as you do those maneuvers. Again, in that regard, I think the maneuver simulation is quite good. I'm just inflating the anterior chamber. You can see there's quite a bit of bubbles. Because this is a rather stiff eye, anytime you go in and out of the eye, you can get bubbles in these simulation models. So this is the right-angled Capsulorhexis hydrodissection cannulas that I use. I go out contra-incisionally, point the tip down. Normally, you'd see a nice fluid wave that's formed. In this case, I don't see that. I start to sweep on underneath the rhexis edge on the left side. And you can see that the capsule itself is not really adherent to the lens. Again, this is not like a normal eye. A normal eye, the capsule and the lens are adherent. And that's why you have to go in there with a cannula to separate the lens from the capsular bag. In this case, you could tell they're rather disassociated. I'm trying to turn the lens. You can see it's turning a little bit, but as I'm turning, the peripheral lens pieces start to fall apart. Again, doesn't quite simulate a real patient, but again, the idea, the maneuvers, and getting used to working in a small incision with micro instruments, I think in that regard, it does quite well. Again, I normally, at the end of the hydrodissection, I just flush the surface of the cornea, and out of habit, I did the same thing, and now I have all this water on the surface of the cornea. And again, this doesn't do quite well with that. I tried to find my incision with the chopper, couldn't find it, so I just make another incision and go in. Bevel down and start to remove the surface epinuclear material, just like my standard technique now here. Removing some of that peripheral lens material, go underneath the rhexis edge, rotate the chopper vertically, rotate the phaco tip vertically sub-incisionally, and fracture the lens. The lens does fracture, but you can see it doesn't create the typical fracture points because the lens is rather brittle. So you saw that I was able to fracture, but it actually fractured on the right side. It didn't get opposing fracture points, so there's two heminuclei. It kind of fractured in a rather jagged way. The folks at Bioniko also told me that you want to use more ultrasonic energy than you're used to with these artificial eyes. And so you'll see perhaps the CDE is going to be much higher when I do this case, as they recommended use more phaco energy when you're trying to remove the lens pieces out of the eye. So essentially, there's not much endonuclear material anymore on the right side because it got fractured out. And you see I'm using the chopper to loosen up that left heminucleus. And you see I was able to get around the lens equator, hooking the peripheral lens, and I was able to pop that third quadrant up. You can see there's a quadrant in the subincisional lower left side. There's some free fragments I'm trying to remove, and I'm going to get under the lens piece. You saw that maneuver. I got under the lens piece with the chopper and twirled the tip, and I was able to hook the peripheral lens and pop that last quadrant up out of the bag. Now, one of the things I noticed, and I think it's because I didn't clip the cataract component of the device into the chamber with the iris and anterior chamber very well, that you can see that the cataract is actually slipped down into the left. And you see, remember the rhexis was well centered, but now the rhexis is decentered down into the left. And it's because I didn't really do a good job in seating that cataract component into the device. And so now this is a single piece acrylic lens. I put some cohesive viscoelastic into the bag, and I'm delivering the single piece acrylic lens into the capsular bag as well. All of this is fairly routine and rather easy as far as the maneuver simulation, placing the lens into the capsular bag, injecting viscoelastic. Again, maneuver simulation wise, all of this is quite good. Again, from a tissue standpoint, you have to take it with a grain of salt. The lens disassembly was not typical of what you would experience doing cataract surgery. In this case, because the capsulorhexis is decentered, again, because it slipped, I decided why not go ahead and just widen the capsulorhexis. So I used long Venice scissors to cut the capsule, and I'm going around trying to extend that capsulotomy and make it more centered here. So again, in these types of maneuvers, cutting that capsule, extending it, and following it, all of that, again, very reasonable as far as learning the maneuvers, again, working within a small incision and learning how to pivot within the incision, moving your fingers around so that you can get around the lens pieces, doing the maneuvers of using ultrasonic energy and vacuum, understanding the principles of fluidics and phaco energy and how deep to go and not to be too superficial when you're doing ultrasonic energy. All of those concepts and depth of view and depth of field and how deep to sculpt and where are the positions of the instruments in the eye, all of those things are excellent with regards to this model. And I think it is valuable for those who are basically on the early learning curve of cataract surgery. I think this is rather invaluable. I think once you do cataract surgery on real humans, the tissue simulation component obviously you'll be able to connect the dots because you're doing it on real patients. So this is not really applicable to that. But I think in regards to the maneuvers, I think it is rather helpful. And again, if you're a medical student or early on in your residency, whether you're an intern and wanted to kind of dabble in phaco, or you are in your first year and you're only doing a handful of cases, I think this is a rather great way to get your feet wet and getting an idea and hands-on experience with cataract surgery. Again, emphasizing the maneuvers and not necessarily the tissue. And so I think this is rather helpful for those folks on that learning curve. So again, this is my first impression and my firsthand experience using the Bioniko BR8 cataract surgery model. So I hope this was helpful to you, and I thank you for your attention.